So OAM navigation is an intraoperative imaging technology which is used to improve the accuracy and the precision over the regular fluoroscopy and the C-arm. There has been limited research on the learning curve for the surgeon, clinical surgical staff as well as the technician for the OAM and its usage. Background. OAM, which was introduced in 2006. Currently, the paper which we have made, we have used a second generation OAM. This is a mobile intraoperative 360-degree cone beam CT system. The advantages of this are it has a breakable gantry which allows the OAM to smooth flow inflow of the OAM and avoids any hassle-free collision of OAM with the OT trolleys. It has a 360-degree scan. It allows there is reduced artifacts. It allows quick registration without wasting any time. There are real-time 3D images showing sagittal, axial, as well as coronal view of the vertebra. Then it has improved accuracy and safety of fluoroscopy and CT navigation. The aim of the study is to bridge the knowledge between the learning curve for the surgeons, then systematically evaluate the learning curve and evaluate the outcomes and the patient safety for OAM. Materials and methods. We included the first 100 patients undergoing spine surgery under OAM navigation by a single experienced spine surgeon. Demographics. We included all age group and thoracolumbar pedicular screw fixation, including degenerative diseases, unstable spine, deformities, as well as fractures. This was a prospective study. Parameters to be looked upon were setup time, pre-instrumentation time, instrumentation, and post-instrumentation time. Then we assessed accuracy at the end of the OT and its loss, which requires revision. And therefore, the third OAM spin. We divided 100 cases into 4 quartiles and compared outcomes of each quartile progressively. For this, we trained 2 OT technicians and 2 surgical staff for a period of 6 weeks with demos, lectures, and they assisted the senior staff first before starting the cases. Considered variables were age, gender, screw site, and the surgery, was it minimally invasive or open. In pre-instrumentation time was defined as the level setup time, what vertebra level we are operating at. In the first OAM CT scan, which acquired all the images into the cell system, then the laser marking, so that next time when the OAM comes at the position, there is no time wasting. Then registration errors. Instrumentation time was defined as a tracker identifying then entry point to the last to insertion. Post-instrumentation time was defined as the second OAM spin. Then we identified the accuracy and we assessed for any breach according to Gertzman and Robbins classification. This image shows the OT setup where we take in the OAM to the correct level and levels are marked, laser marking is done with the OAM. First CT scan is taken. When the OAM shoots are taken, the surgeon, surgical staff as well as the anesthetist all are not exposed to the radiation, reducing significant radiation exposure. So this image shows the navigation reference clamp we have applied at a cranial end to the spinous process. Then the tracker is identified, then incision taken and the dissection done to reach the entry point of the pedicular screw. And it is confirmed.
Doctor, you have less than 1 minute. You have less than 1 minute.
Yes, this is an optical camera image showing optical camera image showing MI screw and the polyaxial pedicle screw. Then the images showing a pedicle entry point, navigated probe with screw trajectory shown in this image. This image we can accurately consider the length of the pedicular screw to be inserted, then navigated tapping of the pedicle so that we can see the sagittal and coronal images, medial, superior, inferior as well as lateral walls. All walls can be seen. Then 3D scan at the end of the screw to assess the breach. Results. Demographic data, mean age was 52 years, 61% patient were female. Procedure type 13% was MS, while open was 87%. levels were majorly it was lumbar level. Clinical presentation, we had low back pain and radiating pain as the with VAS 7 and 8 respectively. Number of screws 7 median screws per patient. Breaches 6 screws were breached out of 627 total screws. Accuracy was 99. This is a Gertzman and Robbins classification where grade A is less than 0 mm, B is less than 2 mm, C is 2 to 4 mm, and D is more than 4 mm. This is the preparation time. Graphs showing preparation time, pre-instrumentation, instrumentation, and post-instrumentation time, which was all constant after the second quartile. So discussion, accuracy is crucial for preventing neuronal injury, pseudoarthrosis, and ensuring construct stability. And no breaches observed in the last 50 cases, which suggests that the improved accuracy with increased experience. Post-operative, and only 5 out of 627 screws required revision, indicating significant decrease in the need for intraoperative revision. So we conclude that significant decrease in the operative time after the initial few cases. There is a steep learning curve in the early phase followed by a plateau. And substantial improvement in the initial cases after surgical precision, placement time, and reduced complication rates. Thank you.